to our webinar today. My name is Anne Palmer. I'm the CEO of Race Excellence and my co-exec, and also our presenter for today, Rosa. We would love you to turn your cameras on. We are recording, so if you don't want to be seen, then obviously don't do that. But we would love to see some faces today. Your microphones are all muted at the moment, but we hope today will be interactive. So at some stage you will be asked to unmute and contribute accordingly. Our webinar will progress right through to 3:30. There's so much for you to see, to hear about. The content is just fantastic. The main thing, and I suppose what makes Race Excellence distinctive, and what has also joined us with the Global Equity Learning company, is that we very much don't just talk about it, we move through the process and we ensure that people have the support that they need to actually implement some of the things that we're talking about. So welcome again, and on that note, I will pass through to Gifford.
Hi everyone, I'm Dr. Gifford Ramey, and it's my pleasure to co-host today's podcast. It's a joy to be working with Anne. We run Race Excellence, and if you have experienced some of our deliverables before, you would know that we are serious in the work of ensuring that notions of inclusion and belonging are embedded in the workplace, not just as theory, but as practice. And today we are excited to welcome to this table Dr. Rosa Colon-Colaco. Dr. Rosa is a global leader in health equity, organizational transformation, and diversity, equity, and inclusion. She has over 25 years of experience and has worked across healthcare, corporate, and academic sectors, driving systemic change in equity and social justice. She is a recognized authority on health equity and has developed and implemented work frameworks for integrating equity into healthcare systems, workplaces, and policy making. We invited her to bring her expertise and some of her experiences, to share some of her experiences on global health policy, workforce inclusion, and community health initiatives, with a focus on reducing disparities through data-driven strategies and sustainable change management. Dr. Rosa advises governments, health organizations, and corporations, and she uses AI and data dashboards and self-assessment tools to help measure and enhance impact. And we're delighted that Dr. Rosa Colon-Colaco can join us in empowering you and inspiring us to see how we can drive meaningful, measurable change in health and equity, both in our communities and worldwide. Welcome, Dr. Rosa. Over to you.
Thank you so much, Dr. Gifford and Anne, for this opportunity. And I'm very excited and also honored to be here with you today and for you to taking the time to talk in such an important topic. I have done this work for more than 30 years, many of them in other countries. I live and work in the UK for 4 years. And for me, it's all around people, taking care of people, giving an opportunity for people to excel, and also bringing people together. All of you here have expertise, so I'm honored to be in front of you. We have a lot to learn together. And I'm here to tell the story of someone that have done this work, but also in different roles. So I have been from a chief people officer, an HR officer, to a chief equity and inclusion officer at a state level or different locations. And what is important is how can we integrate the work to work collaborative in a way that we can make a greater impact. So I'm going to bring different lenses, so you need to bear with me. And then I'm having some issues with technology. I'm hoping that you can see the presentation right now. And it's in a sorting mode, but every time I try to put it in the screen mode, it's really a little bit difficult. But what I want to say is that I want to start with my story. I'm original from Puerto Rico, very honored from a Latin woman from Puerto Rico, and my mother, who now passed, and I'm going to talk about her because she's a lot to do with equity. She always told me that it didn't matter how much resources, social or economical, we have. We needed to have a vision, and we needed to have something that we wanted to do. I always dreamed to travel the world, and thinking that I would never be able to do it. And then here I am. I did this in so many countries. But what happened is that at the moment of her passing, I have a very bad experience, and I worked in pharma for 10 years. And during that time, I experienced a very high level of inequities during her care. So when I was finalizing my PhD, and she was so excited at the graduation. She never finished high school at that time. And she passed away 30 days before the graduation. But what I experienced was a broken system that didn't care too much about her differences, and much about judging who we were versus care for our people. So I shifted healthcare from the life sciences and research side. When I worked even in Latin America, I was in charge of Latin America for auditing and compliance, in addition to HR. And I decided that I needed to shift to health systems and healthcare delivery system to make sure that we look into ways to make it more equitable, and in a way that we can save more lives and give people this chance. She will be 90 this next week, and she's in heaven. But I do this because it's a mission in life, and I do my best to, from our academic credentials and everything we are doing in academia, we research, making sure that we create evidence-based solutions, but also advance the work. In some cases, we have many models that confuse many people. So I will try to make it practical today, and we will engage you in this process. As I said, I'm not the only experts in the room, and I respect many of the experts that are here today to listen to this discussion. So this is what I call our learning journey. So what we're gonna do, we're gonna start exploring what is the definition of health equity from the broader perspective. We're gonna ask you, oh, what do you think about this topic? My partners, Dr. Gifford and Anne, will be part of this conversation, engaging conversation. And then we're gonna see a global perspective. I will give us also the US perspective. I think you see some of that in the news. We don't want this to be a distraction, but we know there are many changes of leadership around the world, and when leaders change, some priorities change. So we're gonna talk about that in our model of health equity, when collaboration with government at state level, at a national level, is so critical to avoid that suddenly somebody comes and the equity agenda changes and everybody's life get impacted. So we're gonna talk about that. And we're gonna talk how to measure. I believe that if we don't measure things in a way that is credible, it's not very easy to get attention, to get funding, and in a different way. We want to celebrate. This is not easy work. It's hard work, the work of inclusion, belonging, and equity. So how can we measure different angles that in some cases is not necessarily numerical, but how can we make sure that we take into consideration everything that have to do with the impact we make in different angles of the organization? We will share some research we have done for the last 10 years that took me to the models I will share today, and we will talk about this collaboration. So soon enough, you're gonna be the one speaking here or to type in your ideas. But when we think about equity from all angles, impact people's lives in so many levels. But if we start with health, as Martin Luther King used to say in America, that from all the inequities, health is the more dramatic and more impactful. At that time, when he was alive, many people were denied care. Not only we were segregated, many people were not able to go to some hospitals. And we still have some challenges on access from many different ways. If we see the media, in some cases, some people think that equity or health equity or sometimes diversity is not good for business, or it's not something that we should not do. However, as somebody that have done it for so many years, I have seen how we change every day, every encounter, the life of someone. It can be because you can see somebody that sometimes is not visible to you or to others, that you elevate voices from our communities that are the one that can help us with solutions. In America, we use a lot of community health workers out there, that at the end of the day, it's not so much the physician who can do this work, it's people out there that you trust. So from the broader market perspective, you'll see some numbers that when you increase market share, involving and giving access to all, regardless of who they are, they also financial and revenue definitions. And the community trust, in some cases, is not there because we design solutions where people are not involved and we don't allow them to teach us with their lived experiences. So you're going to hear this term in America that we use a lot as well, those lived experiences, to make sure that we know what people who have gone through diseases or have their villages when I used to live in the UK or in other countries, they have solutions that sometimes they cannot afford to build. So this idea of the community to be at the table, elevating their knowledge, counting their knowledge. Sometimes their knowledge is more important than even my PhD, because they know how the things can be fixed in their communities. So we're gonna start with our first discussion, and I'm gonna introduce Anne, and you're gonna help us with this. So we want you to think, what is in your mind? You log in today for this conversation, and we want to know, when you think about equity from different angles, what comes to your mind? And we will allow you to chat and share your thought. And if somebody wants to also be off camera and share something, please let us know.
Please feel free either to use the chat or to put a virtual hand up. If you could just come off share for a moment there, please, Rosa, that would be really great. What word comes to mind when you think about equity? We've got some contributions coming in through the chat. Fairness, opportunity. Access. Anybody wanting to make a live contribution? Essential.
There's one that says, more than equality, it is about putting in place all that is needed to support and empower more vulnerable or undeserved groups.
Equity to me is meeting people's individual needs. Meeting the needs based on their individual needs, opportunities to ensure that everyone receives the same. Maybe one or two more contributions. Please feel free, type in the chat. Is there anybody that wants to come on camera?
Somebody have a burning idea or something that you want to learn today? Please let us know.
I can see Sarah sitting at the edge of her seat, not meaning to call you out, Sarah.
You're the only one with your camera on, Sarah, so I think you're going to be our star pupil today. Fair and right. Did you want to say something, Sarah?
I think it's just the opportunity for people to flourish. It feels like that, giving them the opportunity
to flourish.
We like that word.
Yeah.
Definitely. And Pamela, you're at the ready.
I'm gonna pick on Pam. Pam and I go a long way. We did our PhD together, and a research. So Pamela, I'm so honored and excited you're here.
Oh, I'm honored to be here to support you. That was one of the reasons I participated, but also interested in the topic. But looking at equity, I find that equity does not equal equality to me. Everyone has different needs. So, when I looked at the word equity and I looked at the different needs in the organization, I said, treat people the way they need to be treated. That is equitable and fair to them, because everyone has different needs, and we all may need a ladder, but my ladder may need to be taller because I'm shorter versus the person who's taller. So I see that you have to really be vested in the individual, look at their specific needs in order to make it equitable for them to obtain the same, because we may have differences, different systems in place that may not have brought the fairness, but then the equity brings the fairness based on the individual need.
Thank you.
Thank you for that contribution. And we've got Gloria there before you move on.
Hi
Rosa?
everyone, can you hear me?
Yes, we can, Gloria.
I've got an issue with my camera, so apologies about not coming on, but hopefully you can hear me, and apologies if it cuts out. But completely agree with what Pamela said about the ladder, and some people might need a taller ladder. So for me, really passionate and do a lot of work around race equity. And so equity for me means it's okay to put a strategic and a tactical prioritized focus on race, and not be like, what about all the other protected characteristics, and watering down what we need to do here. Because, what I've seen is when we're at the, we're at the start of making a real difference, we then start getting the whataboutisms and what about my ladder and the other ladders, and then we don't get anywhere. So for me, equity is being supported and empowered to just focus on race equity and not having to do the work for every single other protected characteristic.
Brilliant. Thank you. And thank you, Crystal and Em, for your contribution in the chat there also. Back to you, please, Rosa.
And I think I saw Gloria have her hands up. Gloria, do you have your hands up?
Oh, I already came in.
No,
She just came in.
She just spoke.
Okay, thank you. So I think when we talk about equity, and thank you for Gloria to mention racial equity. Sometimes we are so close to the work we do every day, because sometimes we do it with a lot of lack of resources, that they don't think about that equity is a global issue. If we think about COVID, and we think about how people travel in maybe 50 years ago, we didn't travel this way. So sometimes I talk a lot about equity and think about global health in a way that people need to see that this is not only that it's a problem. You know what I mean? Sometimes people see it as a problem. I always remember when I was teaching at Thomas Jefferson University, a PhD for strategic leadership, and I have a whole group of midwives. The whole group were midwives, and they wanted to be PhDs. And one of the things that they were talking about equity, about power, and the issues that they have, that sometimes the obstetricians didn't give them enough time, and that they were not really working as a team. And they spent time talking about how they were doing a project globally to change standards for midwives around the world to be able to travel and work in different countries to make sure that we have the same requirements. Because sometimes we know that when the midwives come, for example, to the US or the country, they need to go back to school, they need to take an exam. So if we think in a global perspective, then we see that it's not only a challenge, but it's an opportunity that we can look into solutions, or even look into other countries' solutions to do this work. And there's so many examples. I can keep going, but I know we have all the topics to cover. But I'll also looking into the law of equity cost in Massachusetts through the Health Equity Compact work. And a shout out to Health Equity Compact. I'm an executive member of the board. And in Massachusetts, where we are working at a government level with the state, with the governor, with the Secretary of Public Health, and we did a study with the Foundation of Blue Cross Blue Shield, and we discovered how inequities impact everybody. It's not white people, different races. There was racial, there were white people inequities, and it cost like $5 billion to the state cost, because we are not preventing people being healthy and they go to the hospital, to the ED, And you can see here in the European, like 5 billion, 9.6% of European GDP is cost of health inequities. And I'm sure there are even more, because many people don't allow to know that some people don't really have data they like to share. So when I founded my company 10 years ago, I wanted to say that I envision a world where we can come united instead of competing, to collaborate, to make sure that we share knowledge and making sure that we think about the impact we can make and work together. And then when we think about the ladder, somebody mentioned the ladder, and I know there's so many different pictures of this, of equality and equity. There's one that people are trying to get an apple. There's one with a bicycle, because we also need to think about disability sometime, or eyesight. What about if I give you a different ladder, but you need glasses and you don't have money to buy glasses? So what I'm saying is that there is a rhetoric lately that we need to pursue equality. And I think, Pamela, thank you for your comment. But in reality, many people will need many different things. And sometimes they don't even share what they need because they are embarrassed. Yeah. So there is a connection between that and trust. So the idea is that when we think about equity, we need to think about from disability, from LGBTQ. There are many things that some people go sometimes to health system. I'm going to have a quick story. I always remember, when I was in one of my state level appointments, and I was working at in a place I was the chief people officer and chief diversity officer, and I was in charge of language services. And one evening I get all these text messages that we had this incident, can you reach out? And we have a patient in the OR that it was ready for a surgery, because when that person was diagnosed, they thought it was a hernia. And the reality was that it was not a hernia. It was a person who was going to transition, and there were some parts of his body, everything that happened during that process, the hormone changes, your body changes. But that person was not comfortable, to really talk about who that person was. And we were having a lot of education about how to treat people in the LGBTQ community. And even in the New York appointment when I was there, we even created a certificate with Fenway Institute. And we certify our professionals on how to treat LGBTQ professionals. So we need to think about that equality is connected to listening, and it's connected to listening, and also to make sure that we look into the individual as a whole. And we're going to talk more about that in a minute. But the reality is that many of the outcomes are avoidable, but we need to look at the system. And we're going to talk a lot today about how we make change through a system lens. So the work I do is not about looking into training, but looking into what is the system. Because if we change the system, you look into, I can only change one thing because this impact another thing, maybe not positively. So we need to look at this as a systemic process and as a change process. So we're going to talk a little bit more about that. Then I need to make a big connection between the work of inclusion and belonging and equity and health equity. Very often, individuals work in this agenda. I've been blessed in my last two executive C-suite role, because I oversight health equity and inclusion and belonging. In some organizations, people are in separate roles. There is a health equity officer that looks into the patient data and services, and there is a department trying to build inclusion and belonging, but they don't come together. Well, the reality is this is intersectionality at its best. So what it means is that inclusion, sometimes we have issues in a clinical area with infection for patients. I'm going to give this example. And sometimes we struggle to find why this is happening. And we have a case that it was the person who cleaned the room and bring the food who made observations about something that they believe were causing these infections. So we didn't ask. We normally go into a huddle and we bring all these nurses, physicians, and everything else, but we don't bring everybody. So that the idea of bringing people to share their knowledge, their observations, but also making sure that by doing that, we are doing something that is equity at the bottom, which is constantly and consistently recognizing that we need to share power. That sometimes the power is not shared in the patient relationship. Sometimes when we design systems that I have designed, working with Workday and Epic, we think the technology people have the answers, and sometimes they don't think about how it will be used at the floor or in that store, so in the community. So the idea of the power, something that I want you to think about. And do we have the dominant group making those decisions? Who is at the table when a decision is made to change policy, to change processes? So I see in America, we call DEI, and you have seen in the news all this negative rhetoric, and many people don't understand DNI. But for me, if we forget about the label, the commitment is that we want people to excel in their careers, because if they're their best, you're going to have the best customer service, you're going to have the best solutions. I was with a C-suite executive doing a conversation, and it was nothing to do with healthcare. It was a consumer products. And they were like, well, why do we need to talk about inclusion and all of this? And I give an example of how the new generations, the alpha generation, at least in America, for the first time is 52%. So the people growing, that they're going to be the future generation, alphas that we call it, it's the first time in our country that is the multicultural individuals that are the power. They are for 52% versus 48% white. So what it means is, if you don't have products that are relatable to those populations, what I did, I bring a product to the C-suite and say, I bought this product with your competitor because you don't have this. And as a Latina that like different things, this is something that is very relatable to our population. And from the alpha, and we are like 25, almost 30% of the population in the US, meaning that if you don't have something like this, they're gonna go to your competitor. So think about this as a business, because it's a business. So it's not about only investing money. So this is what is really important, that we thinking about that connection. And some of you may have doing that already. Then when we think about from the healthcare perspective and other things, not only health, I love the United Nations Sustainability Development Goals. They've been around since 2012. And they have so many areas, from eyeglasses, from water, from environment, everything is in here. And what is important here, they talk about climate action, they talk about quality of education. So the United Nations is the best example of a systemic change. So they didn't go out there and say, let's do health equity. They went out there to create areas that the world needs to address. And what they're saying is, this is unique by country. I think we have here people from different countries. So every country may have a priority, like water. And you think about Africa, people walk miles for water, or the people eyesight. So what it means is, they created this to allow countries around the world to pick which is more relevant to us in our country, and pick one or two projects where people can work together to make a difference. So you can see this, like your company, in your company, some organizations are very big, have different consumer products, health products, climate products. So it's gonna be like, do you know in your organization as a system, what are equity issues that you want to bring together that will make an impact to your business and to your constituents and your consumers? So that's what I look into, the systemic way to look into health equity and equity across organizations, which I have done in a couple of places. Then this is an example of the one on healthcare. Number 3, global health and well-being. They talk about maternal mortality, which is, I think, one of the number 1 causes of death in America very often. You will see some statistics. They talk about diseases So how much by 2030, how can we take AIDS and other diseases that we don't talk too often about, but they're still around? They talk about how can we end preventable death under 5 years of age, going back to the decisions we make impact children, and how much of those resources they have. So you can read the rest here. But the idea is that is one target around the world where people can do things together and also can share best practices. There's a ton of things. There's a beautiful video that we don't have time to share about the different people around the world talking about what goal are they working on, how they're implementing their solutions. Also, when we talk about global health, because I started talking a lot about that, we talk about mortality rates. So you can see in the global mortality rating here, you see that there is a correlation of countries with lack of resources, social economic status, education status, and life expectancy. So it's not that we're lucky. It's because if we have a higher life expectancy depending on where we live, where we play, where we work. And then you can see in here, you can see the numbers. What are the countries that have the highest global infant mortality? The US have it quite high as well. So sometimes I ask people, do you know the priorities or where you live? Do you know what is going on in your village or zip code? Or do you know, because sometimes people only know their village, or their neighborhood, they don't look broader. So I'm gonna ask Anne to help me playing a video very quickly for a few minutes about the European health inequalities that we see here. So we wanted this to be a global conversation. So I'm gonna stop sharing, Anne. Thank you, Anne. So we can keep going with the video, but we have so many things in here. So we wanted to give you, we would share the link of the video. But I think what is important here is to know that going back to the concept of across the world, languages are similar, inequalities, inequities, life expectancy, mortality rates. So there's so many ways where we can really come together when we measure things. And particularly when we think of things about depression, anxiety. We know, I was reading an article in the US last week of how after the election, people are feeling higher levels of stress, anxiety, and how they impact not only their work, but also their health. So this is all connected to life expectancy. Okay, sorry for that. So
Much better.
much better. So I mentioned to share also some statistics about the demographic shifting, because this is also connected to the US. I also talked already about the alpha generation and how here it's at 2050. This is the Callow Foundation and all the research they do in this area. One of the things that I wanted to cut your attention here as well is how the infant mortality and disparities resulting in an additional 3,000 Black infant deaths annually, and this has increased a little bit after COVID. We talk about how that contribute to Black life and cancer mortality in other populations. So it's really connected to racial equity, as Gloria mentioned. And sometimes we just need to look at data this way. And but I want to emphasize the importance to look as well into ethnicity. In the US, we call it ethnicity, and in Europe, we call it country of origin, because different population have different genetic that impact their health as well. The next page talk about what I mentioned about recalibrating and thinking about the power of looking at this as a business perspective. You know, in America, we know everybody have health insurance. So, and also the health insurance literacy, what we mean by that is we write a lot of beautiful collaterals and information on health insurance, but it's very high level in the literacy. So people sometimes cannot understand, you know, how can they leverage services that are preventative, and how by doing that, organizations that have insurance can increase their revenue, but at the same time, you know, patients have less risk of having that disease. So we know that in clinical trials around the world, people are trying to improve representation. We still have not increased enough in the US. And there's something that we're working on, but the numbers haven't changed very much. I think they're like less than 5% representation of Hispanic population in the US for clinical trials, and maybe around 8% of African Americans and Asian, a little bit lower as well. So this is for you to see the issue or opportunity of this page is sometimes we have data, we don't know how to represent the data when we go and talk to other people, but it's important to look into both aspects so people can see the importance of from both. It's a business imperative and it's a life is also imperative through numbers. Then we talk about how where you are, how place matters. This is an example of the study in Massachusetts where I have been working for the last almost 4 years, and how neighborhoods, if you've been in Boston, Massachusetts, you normally go to Back Bay, where Harvard, MIT, all the beautiful universities are. And here is very close also neighborhoods around them. And in reality, they may be 10 minutes away, sometimes not that. And their life expectancy may be 20 years difference. So we have goals sometimes that you see online that we want to improve life expectancy, the investment for the government, from the state, from some donors to see how can we make this better. And I wanted to mention about policy changes. This is also connected to segregated communities. So we call it redlining in the US. This means that back in the day when Massachusetts was founded, land was divided in a way that minorities were able to afford locations less than other locations that have more access to parks, to waters. So there are things that happen that still impact people's life today. And in some of the area that you see in that circle is during the summer, those areas that are maybe less attractive to live get very overheated because they don't have close water or beaches or parks to walk. So there are policies that we just need to maybe look into that have been around for a very long time to be able to impact equity. And that include also in HR and also how career development. So it's not only a health issue. So I'm going to pass this baton to Dr. Gifford that is also going to talk about the UK.
Thank you, Dr. Rosa. A very interesting message in the chat of a piece of work done in Bradford of people born there over the past 15 years. Some research has been done, and they highlight emerging health inequalities across ethnicities. And this is despite the intersectionalities that are there. And felt that we should just quickly share on this slide really a reflection on what Dr. Rosa has already established as happening in America. We see corresponding data here in Britain of the type of inequities that there are between differing peoples of race or ethnicities. So I'm just going to pick out a few of these. I'm not going to go over all of them. Some of you might be well acquainted with these, but if you look on the right table, there are black women are 4 times more likely than their white counterparts to experience death in pregnancy, and that's mega when you think about it. 4 times more. I was doing a presentation to some health personnel not too long ago, and they were on the main they were quite ignorant of these figures and these challenges. So it's useful to just hear this again, I think, sometimes. South Asians are 40% like they have 40% higher death rates than their white counterpart. If you look onto the right-hand side, it says that black and minority ethnic people have up to 2 times more mortality risk from during COVID than their white counterparts. And there are estimates about disability as well, that 10-year there's 10 years less expectancy of life for people in for men of Bangladeshi background. So there are strong correspondences between this, and just to demonstrate in the next slide how this also pans out on postcode drifts. So I just plucked this example out. This is Buckinghamshire. It's not personal, all right? So I just plucked this out. And Buckinghamshire, which is just outside London, for those of you who don't know. Here you see on the left-hand side the ethnic population distribution. The lighter the shade, the more it is representing the majority culture, the majority ethnicity of white Anglo-Saxon primarily. The darker the shade, the more concentrated people from minority backgrounds live. And if you look on the middle map, you can easily superimpose that middle map that demonstrates the deprivation quintiles within Buckinghamshire. You can easily just superimpose it onto the left hand, and you will see that the concentrations are very similar, where the higher the risk, the higher the deprivation, it corresponds with the density of the high densities of people of minority backgrounds. I think I will just leave it there, but it just demonstrates that it is that inequities are in many ways that are attached to one's socioeconomic background and also one's race, because often minority groups or people who are racialized as minority groups, they often occupy preponderantly the lower socioeconomic classes. I think I will just leave it there for now. You could back to you now, Dr. Rosa.
Thank you. I encourage if you have any reflections to share in the chat about this the power of place into where your health is. And sometimes career opportunities sometimes are connected to this. I wanted to say that, and also health. So it's important to think that way holistically because it's all interconnected. So let's talk about what are the barriers for health equity in this particular case, because that's what we were talking about, the places. There's an element here that sometimes we don't talk too much about, which is about our brain and the neuroscience of biases that we have around people. And I always say about the brain, because some people, we think about bias as a bad thing, but they're not only bad, you know. I always say that our mothers taught us not to touch the stove because we can get burned, you know. So that's a bias. We go and we know it's gonna be hot. So we just need to think about how we address the organizations that I know that have done a lot of work on creating anti-racist organizations and cultures. Sometimes this is not a word that people want to talk about, you know, so particularly in some of the environments we live today. But what is important is this is a research for the Blue Cross Foundation, Blue Shield Blue Cross Foundation, and they did more than 50 interviews with communities. And they asked, you know, what are these really barriers that you see in your communities about why you don't want to go to the physicians or to the clinics? And many of them address how they felt treated and how they feel that there's not a way to not being judged. Sometimes we judge individuals because they're not adherent to their medications, and sometimes it's because they don't have the money to really buy all the medications. If you're in the US and you don't have insurance, so or they need to work 2 or 3 jobs and they cannot go to a physician because the hours are not equitable. So think about that into something that, going back to the D&I conversation, it doesn't matter what you call it. You know, if we can call it civility, some people call it civility at work, civility with others. But it's important that we cannot underestimate that is what is in people's mind very often. The lack of access, you know, of going back to a global America or the global Europe and all the people migrating to different places, language differences, you know, culturally competent care, what people believe health means. I always tell people that I share my journey from so many countries, including Asia. You go to different countries, how they define health and healthcare is very different. If you have a health system that is across the country, your perception of health, for example, preventive care in Latin America is something that we don't talk about. You know, preventive care is something if we talk about, oh, do you have a primary care physician? They're gonna say, what does that mean? For us, it's a family physician. They used to come to my village. So it's just thinking about how people relate to health is very, very peculiar. And we just it's not only about language. People think cultural competency is language, but it's a combination of many factors that are really connected to social needs that sometimes we don't address enough. When we talk already about poverty and social needs in the economic status, and many of that connected to your level of education, and you saw in the video, and your stress connected to that. And the mistrust of the system. So I don't know how it is in all countries, but I know that in America, we still have a lot of mistrust, particularly during COVID. More people of color die at a higher rate during COVID in America. And there is a video from Oprah, The Color of Health. And they have real stories of people rather die to go to the hospital for care. And families talk about how that impacts the whole family to see that they don't want to go to the health system. So it's not that our health systems are scary. We have many, many places that people have great care, that people have built the trust with communities, but they have been very intentional, you know, to do that work. That is not a nice to have. It's a way of working. So I just want to recognize that. So this is a little bit of a picture of how do we define in the Bay Area, where I have worked as well, a little bit about how do we see from upstream to downstream. So if you think about how we normally focus a lot in our institution, our healthcare system, and our location. Sometimes when we think about equity, when we design systems, we design buildings, sometimes we don't think about, will people have transportation to get here? Do they need to park the car? Can they afford the parking? So we spend time looking about the institutional conditions, but not necessarily the inequities of law, regulations. So going back to the systemic theme of this discussion, so we need to look at this and think about, so going back to the social determinant of health, so what are the living conditions of people before we start judging they're late for an appointment? Maybe because now they were a caretaker, they're taking care of their grandma. So there's a lot of living conditions that we don't talk about. So the idea of community, I did mention community health workers and the importance of them. I want to talk about that a little bit. Dr. Atul Gawande is one of the big thinker of healthcare and transformation in America, and he traveled the world looking into where are the places where people live the longest. They found that in Thailand is one of the best, is the highest life expectancy. And what is curious about that, they have more than almost 1 million community health workers, and they have shifted the money from the building of the hospitals to the community, where they are having community health workers that may not have a degree in clinical, all of them, but they speak the language, they have the same religion, they have trust, and they pay them to go and knock at people's door to see how is your diabetes, how is your high blood pressure. In Costa Rica, is very similar. So what I'm talking about is that we can look into risk behaviors that we know that healthcare is connected to 80% of your health is connected to what you do in back at home, in your community, and 20% in the care we provide. So if we think that way, we start rethinking, where am I spending my time in my strategy of equity in my organization, be it healthcare or not? And where do I need to reallocate my thinking? And how can we take community as the lived experience experts to really help with the social inequities? And by doing that, trust is built. And how will laws and regulations, I'm going to talk about that later. Laws, going back to redlining, how Massachusetts was divided, is something that you see that is really very important to think about, because they have big play that sometimes we say, well, I cannot do that. The law doesn't allow me to do it. But why do we have a collaboration of people that can challenge that law and advocate with your legislators? So the idea is that making it in a way that people see it, that is all connected. So another thing that we have done in the US with health equity is creating requirements. So what it means is around 2015, we created the cultural linguistic competency standards for healthcare. I want to repeat, it was around 2012, 2014. We make them encourage. We encourage you to do this. Yeah. However, it's not many people who are so encouraged, So then we realized back in 2022, 2023, we say, well, people are not doing the right thing. So we need to create some requirements. So requirement means, at least in the US, that accreditation bodies for academics, health system, community health systems, they have accreditation visit every 3 or 4 years. So what you see in here are organizations that have embedded equity requirements into their accreditation bodies. So when the auditor comes, I'm going to give you an example. The Joint Commission, that I remember when I was at Tufts Medical Center, they came in 2020, at the end of 2023. We knew they were coming because they give you a window, and we spent maybe 2 years preparing to show all the work we're doing around data equity, how we collect data, how we share data with others at the state level, with identifying which health system is better than others, how we have data collected by LGBTQ disability, so we're collecting by ethnicity. So how we collect data, but know how to collect data, how can you use the data? So they require that you show them how you're doing this, how the workforce represent the community you serve, how competent are the workforce in culturally competent care according to the different ethnicities. So you see here, community partnership. They even ask, so where are you working in your communities and how? Some of them have addressing racism as a requirement. So this is not about being the police. If we provide some organizations, particularly in Massachusetts, we have a waiver to incentivize more people that if you don't do something, you don't improve, your reimbursement get impacted. So it really costs you money, or you can get more money. So, but the importance in those requirements doesn't have to be only at the state level. It can also be within your own organization. Sometimes I tell people, sometimes we need to have some policies that can drive this change. And we cannot depend from the state or government to do it. Sometimes we can do it internally, something I have done in other places. So please comment if you have something to add. You may have some legislation that you do. We have now our discussion question. I will pass it to Anne. We want to hear from you. You may have some examples as well to share, and you may have some reaction on some of the things I have shared so far in some of the models and systemic change.
Yeah, again, if you come off share for me, please, Rosa. Should we start with Crystal, actually, because Crystal, you've got quite a lot of contribution there in the chat.
Hi, Anne. Thanks. I've had the fortune of working with the Learning Disability and Autism team at NHS England as their health improvement lead. And, from a strategic perspective, obviously there was policy around that. The government took quite seriously the fact that people with serious mental illness and learning disability and autism were dying unnecessarily from preventable premature mortality. That's not to say that primary care does as much as it could do. There's lots of guidance around how they should be undertaking health checks and follow up through health action plans. We are seeing a reduction, obviously, in the preventable premature mortality, but it still could be better. And I think one of the things we definitely saw from COVID was a clear move to flexibility if we wanted to see improvement. So, like you were saying, Rosa, moving out of the clinics and moving into the community, delivering health checks in already established hubs that people felt comfortable and confident in attending, that they trusted within their community setting, particularly within ethnic communities. We looked for trusted friends to get our message out. And to support people to have their needs met. So it wasn't come to the doctors or nothing, come to your GP or nothing. There was lots of flexibility and lots of creation done, which was captured by NHS England, but seems to have gone nowhere really, because there was lots of really great learning from COVID around how we could do things better to reach. I think I put in the chat, I remember one presenter saying, about hard to reach communities, and the presenter saying they're not hard to reach, we just have small arms because we're inflexible and immobile. And I know there's lots of small pieces of work that happen to make that better, but we really need to be sharing that best practice. We need to let other people know it doesn't cost a lot of money. We can use what's already out there. And I know Bolo Loabe from the NHS England Health Inequality team has been doing consultation events around the new NHS plan. And the one I attended, the message was very, very clear that there needs to be persistent and permanent investment in voluntary organisations that work within communities, where we really want to see that improvement from the core 20+5, not just funding for a year or two here and there. It needs to be job safe for people so they can sign up to it and really make a difference in communities and improve people's health outcomes, but also improve that preventable premature mortality. And for me, it's always felt a bit like an onion. If you look at people with learning disability, And then you look at which people with a learning disability have the worst health outcomes. It's usually people from ethnic communities. Then you look there, and then they're in the most deprived areas. Then you look there, and they're perhaps not getting the greatest healthcare because the GP might historically have been a sole GP provider, etc., etc. And it just goes down like that. And it's never just one layer. There's always several layers that they're experiencing health inequalities through.
Thank you very much. Wonderful contribution there. Maybe one or two other people. I can't see faces, unfortunately, but if you don't want to come on camera, you can unmute.
There was one very good other point that Crystal made in the chat, and that was COVID demonstrated that people from deprived areas tended to accept more care and treatment from health practitioners if they trusted them. So so trust is a very key element in this, and hence the point that Dr. Rosa was making about ensuring that with community health workers, that a lot more investment is made in them because they are closer to their communities, and the trust element, the trust factor is quite high there.
Yeah, and that's such an important item here. I think one of the things, there are community health workers associations in America at a national level. They are at a state level. One of the most more vocal is the one from Massachusetts, and they passed legislation to get certification for the community health workers. And also they also have now in America that kind of cost is not reimbursed. So you have community health workers, health system need to pay for that. So they've been working to make sure that they can get reimbursed of that investment, so they can have more community health workers. So sometimes that's the barrier, but they're getting traction, so they're very close to get some approval in that regard on the legislation.
So Rosa, we've got just about 15 minutes before we start pulling things together. So I'll hand back to you. Yeah.
So I'm just gonna go to the heart of, okay, so you're gonna wonder, so what can I do to change what I've been doing for a while, or have a different perspective. So from the work I have done a lot of research to look into where are the key areas that we need to concentrate. They're very similar to the intersectionality of D&I and equity. So when we think about what is our strategy for health equity, we need to think about these angles that we have. I call it the star of equity areas of focus. And you can see here the normal suspect processes and people. So normally we spend a lot of time, and I would like you to maybe think about, look at this like a checklist. Where do I spend my time in health equity? Is it in the physical building and the infrastructure? And also look into the community infrastructure, or do I spend a lot of time in processes and people? I have seen a lot of companies working a lot in the top 3 areas, in people, training, and processes. And sometimes we don't look into our policies that are connected to those processes. So the outcomes that the unequal outcomes we see are just what we designed. So in reality, it's like a recipe, if we have a bad recipe for a cake, it's not going to be good. So we need to think about, if we don't change the recipe from the core, so we need to think about that policy decision, who is at the decision making, the policies of organizations internally, differences between the C-suite, the physician, the culture is different than the nurse's culture. So think about that politics going on. And that is what we have here on the right-hand side, the community health workers. So how designing a system where community health workers are at the center, and how they're there connected to the health system, connected to the physician, connected back to the community. This also applies to clinical trials. So who in the community can be that navigator? Who in the community can be a kind of a trust partner to say, hey, do you know about this clinical trial? Would you like me to introduce? and try to get people to get that kind of information from somebody they trust. But what I'm trying to rethink is, what is the thing that we need to do to address those elements? Then we have a model, a couple of models in here that you can see. One is from the National Institute for Healthcare Improvement, it's the IHI. You can Google this in America. And they do have, in number 5, develop partnership for community organization. And they also have in here that you need to address racism in the organization. So they have a part of the process here. And you don't need to call it racism, but it can be many different things. Then on the right-hand side, it's really like a house. I call it like a house. You have different elements in your house, designing your house. So the House for Health Equity need to talk about data, need to talk about, sometimes you have the data, you have the report, but you don't share it with the right people at the community or people in power to make decisions. So the cultural linguistic care is looking into, I always give an example of, in America, we have Meals on Wheels for seniors because sometimes they don't have money to eat. And sometimes we used to give only American menu to the Meals on Wheels. So many people rather eat conflict, versus really they don't want the meal because I don't want mashed potatoes. I don't want this because this is not what I eat. So the cultural linguistic services is not only for the clinical care as well, it's the support care services that we provide. How can we make it more linguistically acceptable for the community? And how can we involve the community designing those processes, but also evaluating how good are we doing? Sometimes we say, oh, we're doing so great, we're so culturally competent. And then I have done so many culturally competence assessments across a state level, organizational level, and it's amazing the great stories we hear, but also the gaps the community perceives. So we talk about the collaboration. There is a place that you can look, helpequitycompact.org. I'm very honored of this work that a group of 80+ executives of color across Massachusetts created. And right now we've been implementing legislation to make health equity a law. And there's already legislation embedded in some of the government last year legislation. One of them is to make easier for physicians from other countries to practice in America, enabling them for an easy way to accept their degrees and helping them financially in some cases to make some tests that they need to do. So you will see the whole bill if you go to helpequitycompact.org. Then we talk about the dashboard. So I think I want you to see very quickly here our dashboard. It was created with one of my partners, Luminous, and shout out to them. So I have a couple of interns from Tufts University as a professor there. And we look into how many models we have out there of health equity and how we can make it more practical, not only for life sciences, for other organizations. As you see, we created 271 performance indicators. That is a library of indicators organization can select from, can self-assess from. And that includes at the bottom, foundational elements that you don't have it in place is difficult. The idea of the fan won't move if the base is not strong. So we need to have the leaders, the data, the community co-creation, we call it, to bring communities to, how can we measure community advocacy and community involvement, more than involvement? Are they co-owning projects? Are they really at the table designing things? And we also created, we have a framework it's a research-based framework for ETR that we adapted for this work, meaning that connected to the start, that relationship is sometimes more critical than the clinical design of solution. That relationship between the providers internally, the providers and the community leaders, the community leaders with the providers. So those relationships, and we have a whole model to talk about, and we're paying attention to relationship. So it's not about community outreach, it's about community relationship. It's how satisfied are the providers with what they do so they can be excited to meet and serve other people. So then we have a self-assessment to help us know what is the maturity level of my work. I believe that we need to know where we are in the journey and celebrate because it's hard work. At the same time, we don't want this to be a test. We want people to see, are you at the awareness level? There are things you should do, but you cannot do them all. Are you acknowledging, but also implementing solutions to move to a more equitable and equity environment for your consumers and patients, and then you embedded it. Everybody talked to me, oh, I want to embed this in my work. But I want to repeat one more time, I said to people many times, like a broken record, you cannot embed what you don't understand. So we just need to make sure that we need to understand the work, how to measure the work, and then we can embed the work. So it's really a way that has been very successful in organization. And then we created for life sciences as well, a health equity actions checklist. It's only one pager people use to assess where they are. And the dashboard, is also all different elements in here. This is interactive, have different, and you can see here capacity building. We have our workforce prepared to do this work. If the culture is inclusive, do they feel belonging? And I want to say that when I was in Tough Medicine, we implemented a systemic strategy that I didn't have time too much to explain. You can see the framework here. And in 2 years, we increased employee engagement and satisfaction in a much higher level, and maybe more than 3 or 4% increase in engagement, because they saw themselves in this strategy, and they saw the health equity pieces, they saw the technology pieces. So the idea is people normally see, oh, you have a health equity, what about me? What about my career? What about my satisfaction? What about my engagement? So the systemic approach has worked, and we have a little bit of good data to prove it. We also have the picture of the self-assessment. This is also online. And as you can see here on the left-hand side, this is an example of how 2 different departments have a perception differently. They perceive differently the work of health equity. In this case, the clinical team didn't think HR was really doing what they needed to do for equity. And everybody have different ideas, because sometimes they don't come together to plan the work. So this is, and you can see people have strengths and opportunities, and we also provide recommendations in the self-assessment. And this is very powerful when people can see where they are, because the idea, the tool is just a tool. What is the power is bringing people together to discuss those elements to make it work. Then, in summary, the tools that we have designed are very connected to evidence-based practices, and the dashboard has different flavors for different industries, and the self-assessment is customizable as well. And we also have workshop that takes some of these models to the very deeper level, so people can apply, they can customize it in a way. What I have learned that people like to customize it to make it their own. And sometimes we bring community to our training, and they sit with their providers to really learn topics together. And I think that's a very powerful way to do it. And the health equity programming, applying the STAR and the different factors with community health workers, is something that has been very successful in our journey. So I think, Andrew, you want to take questions in the next 10 minutes that we have?
I think it might be good, Rosa, to perhaps talk to people a little bit about where they might go from here. My thoughts, there is so much to sum up, but key things that occur to me, one of the expressions used earlier was who is at the table to hear and listen. And then you made a very strong link with the sort of financial capital, the financial savings, that if we were to get this right, everybody would be listening. But my thoughts are that, we might have some people that are very high level in the industry, in the profession, with us today. But we might also have people that will say, well, I'm not at the table currently, and I don't know how I can influence the agenda. So, just to give people maybe 3 or 4 areas that they might want to focus on if they are at this stage saying, well, I want to do something, but I don't know what it is that I need to do. I think the first thing is to get your voice heard. And how you get your voice heard higher up in the organization is something that we all need to consider. But also in the interactions with parents, in the interaction with patients, listening to patients about their experiences, their concerns, and identifying the barriers. It could be barriers around language, transportation to appointments. It could be around affordability of care, but also educating parents, educating patients about what resources do exist in the local community, because some of them will shy away from accessing, because actually they just don't know that those types of services exist. And I don't know whether it's just London or just where I live, but it appears that our sort of community groups are getting stronger at that, making us aware through the use of mobile phones and messages about things that perhaps we would consider, the resources we would consider using. The other thing, of course, is that on any level, we can also challenge the bias and the discrimination. So speaking up if you witness something, or if you hear something, or if you believe that there is a policy that is really biased or unfair. But committing to your own learning as you have done today, and Rose has been really very clear on the effects of how, if we implement, we can affect patient outcomes. The third thing I was going to mention, the third thing I was going to mention,
and go ahead.
The third thing I was going to mention really was around that whole thing about promoting inclusive communication, using really clear and respectful language, culturally sensitive language with patients and colleagues and people that we work with, and learning what does inclusive terminology look like, feel like in our own day-to-day work. The last thing I would mention really is around technology is providing a lot of opportunities for us to really get involved and to communicate more widely. So how we use communication in this agenda, I think we're already in the middle of it taking off, but we can't see it as something that is being done to us. We've got to see it as something that we are really proactive with. So you say we've got a question here, is that right?
Yeah, maybe I'll read it out, Rosa, and then you can. In fact, there are two questions. So one of them is about constraint of funds, and the other is about how do we translate these models into practices. Where over the years there's a lot of talk about it, but there doesn't seem to be much change. So I'll just read them out. The first one, constraints. Interested to know how we can adopt your HE framework in a resource constrained environment. It can be very difficult to roll out this type of transformation, especially in the current UK healthcare environment. So that's about constraint of resources or finances. And the other one, that was by Gloria. The other one by Advoa. What are your thoughts on how you turn the insights or models into making better and different decisions about policies, practices, and systems? Where I work, this information has been shared over a number of years, but it's not yet changing or influencing the decisions that are made in a consistent way. That is, sometimes an individual will use it in decision making, but another person or area of work doesn't. In other words, there are pockets of application, and but in many other spaces and practices, it's just not followed through. So quite a bit there.
Yeah, well, I think the questions are spot on, the three questions. We have been talking about this health equity issue for the last 20, 30 years or more. But what I want to say about the framework is a framework to prioritize what should I do within my means and my resources. I have been in organizations with very low budget, one or two people, me and somebody else, a team. And normally what I have done is we need to engage the conversation with people that take decisions in other departments. And in healthcare, you have quality and safety, you have data collection. So is that sometimes we're trying to do this on our own, and sometimes we don't quantify. That's what my big lessons learned is not only to say, I'm gonna do A, B alone, but I'm just gonna make sure that I quantify the amount of work required, the people that need to be involved. Because if not, people say, well, this is very important, but you go out there and there's all these other people that need to do work for you to get that done, you know? So I think what is important is to use a framework as a compass. According to this theory of change from Dr. Greg Shea from Wharton University, who the change management model is embedded behind, he said that you need to pick 2 or 3 areas to do simultaneously. It doesn't have to be big projects, but 3 things to change behavior. Because we know sometimes we put we're going to do training. Okay, and the most difficult thing is to change behavior. So what is very important is to use it as a compass, prioritize a small low-hanging fruit that you take data. Sometimes we have too much data. It's not that we don't have data, it's how can we present the data, what to do with the data. Sometimes we have community leaders that are ready to do something, but we don't tell them what to do, or we don't engage them how to design something. Sometimes we don't pay them. In America, we started to provide, give them a stipend to come to meetings. So within our budget. So it's not that we're going to give them a lot of money. So what I'm saying is the framework is to prioritize where to target and to have different conversation from a business perspective. Sometimes we go too much into the social factor and people don't like that. People are saying you only care about the social aspect of the work, but this is the business. So I think balancing business and also assessing the work and reminding people. One of the things that have happened in D&I is that I don't know, people were really understanding the impact of the work. We were talking too much about programs and programs. We're doing program A, program B. But if we translate that into, I'm doing this, but this is how it's connected to your business strategy, and this is the impact I have made, people may have a different perspective. And there's so many workers out there with so much sacrifice of work. So it's all need to be connected to data and outcomes for people to make sure that people can do it and stay baby step. The journey is not to do everything, is to every organization will be very different according to your resources. But I have been in places with very minimum budget, and we have done a great work. Even when I was at Tough Medical Center, and Tough Medicine, our budget was very limited. But we use resources that were doing something similar, and we work together to make it work.
So, I think the message is, I think the message is very clear that sometimes we may feel like just throwing our arms in the air and thinking there's nothing that can be done, but there's always something to be done. And Rosa said 1 or 2 or 3 things. Start small if you need to, but if we do things well, the impact will be there. We have hosted today for you both race excellence and global equity learning. And you can see from the knowledge that Rosa brings into this area, we are fundamentally here to support through a very vulnerable time. If you are interested in the work, it covers anything from using those data dashboards quite extensively for your own organization, having conversations in support of people that are leading the work in your organization. We also do coaching around this for those that are needing to know what next. And we work with lots of global companies and others that in terms of building a strategic plan about how are we going to get this right in the next year, the next 2 years, the next 3 years. And yes, we understand that there are financial limitations, but that is not a reason we believe for not doing the work. It's finding how it can work in our own situation. So we would welcome you staying in contact. I've put a link in the chat for you to connect directly, but also you can find any of us on our associated websites. And I think that Rosa's also put a QR code up there for herself. And really just to pass over to you, Gifford, to close.
Well, just to say, on behalf of everyone here today, it is said that the ones who endure to the end, they shall be saved, and you have endured to the end. So I want to thank, on behalf of everyone here, just want to extend our deepest gratitude to you, Dr. Rosa, for delivering such a powerful insight and inspiring talk on population health equity. It's clear that your expertise and depth of knowledge and passion for creating meaningful change resonates with us. And we look forward then to continuing this conversation and putting these insights into action. So mark this spot, watch this space. You will hear more of Dr. Rosa. We haven't finished with you yet, and look forward to working and changing the world one difference at a time. Thank you.
One difference. Thank you so much.